Hi, this is Dr. Poole, and this is just another brief chalk talk just covering the histopathological changes seen in fatty liver disease. First, I'm going to start with a brief review of normal liver histology, just so that we have a foundation for comparing it with the abnormal changes that we see in fatty liver disease. Just to review the normal microarchitecture, we see the classical liver lobule, which is modeled on the draining of a central hepatic vein. So the red arrows represent oxygenated blood flowing from the hepatic arteries in the triads to the central vein, which is in the middle and marked with H. The green arrows mark the reverse direction of bile flow, which flows from the central, most metabolically active hepatocytes around the central vein back to the portal areas which contain the bile ducts. Often in fatty liver disease, however, we go off of the model of the hepatic acinus, and this is based on the degree of oxygenation or oxygenated blood as it flows from the portal areas. So this model has a wedge shape in which the two corners of the base of the triangle are the portal areas, which are marked by P, and this zone between portal areas is acinar zone 1, and this contains the most oxygenated blood. The area that's at the apex of the triangle, which is acinar zone 3, is located adjacent to the central vein, marked by H, and this contains the least oxygenated blood. This is a schematic, again from a previous presentation, but just going over these different ways of looking at the hepatic microarchitecture. So the hepatic acinus emphasizes the nature of the blood supply to the hepatocytes and the oxygen gradient from the hepatic artery branch to the central vein. Periportal hepatocytes, comprising acinar zone 3, get the most oxygen and nutrients and can most readily carry out functions that require oxidative metabolism, such as protein synthesis. In contrast, the hepatocytes in acinar zone 3 get the least oxygen and nutrients, but these are the this is the preferential site of glycolysis, lipid formation, and drug biotransformations, and these are the first hepatocytes to undergo fatty accumulation and ischemic necrosis. The intervening zone, or zone 2, is where the hepatocytes have an intermediate range of both metabolic functions and oxygen and nutrients. So the key histologic feature in fatty liver disease is, of course, fat, or steatosis. This is the accumulation of lipid in the cytoplasm. If you remember, we can identify two different patterns of steatosis. One is macrovesicular and the other microvesicular. And this type and pattern of steatosis, along with a variety of other accompanying histological findings, are what provide clues to the specific type of liver injury. Now, if we see fatty change or steatosis with inflammation, we call this steatohepatitis. Or if we see fatty change or steatosis with fibrosis, we call that steatofibrosis. And you can commonly see all three of these things happening at the same time in both alcoholic and non-alcoholic fatty liver disease. This is just a high magnification view, again comparing the histological features between macrovesicular and microvesicular steatosis. So with that prelude, let's just go over the histopathological changes with alcoholic and non-alcoholic fatty liver disease. The three major findings are steatosis, also known as fatty change, steatohepatitis, and steatofibrosis. Now, it's important to remember, in fact, it's crucial to remember, that the histopathological findings of fatty liver disease are common to both causes. And in addition, Similar features can be seen in other liver diseases as well, including hepatitis C virus, drug injury, and other causes. So this is a particularly florid example of steatosis or fatty change. In fact, it's actually somewhat difficult to recognize this as being liver at all, and because there's so much fatty change. There's really no recognizable normal hepatocytes. The red circle represents a portal triad, which helps identify this as liver to begin with. Now, the predominant pattern of fatty change, it should be obvious that it's macrovesicular, but you can also pick out hepatocytes showing microvesicular steatosis change as well. This is just to show this in emphasis under higher magnification. Again, most of the hepatocytes show macrovesicular steatosis, but you can identify hepatocytes in the background, such as this one, that show the microvesicular pattern. The second histopathological feature of fatty liver disease is steatohepatitis. And so not only can you recognize the areas of steatosis in this image, it's predominantly macrovesicular, but you can also appreciate that there's an infiltrate of these small cells, which you'll have to take my word for it right now, are inflammatory cells, but in any case they don't belong there. So we have steatosis plus inflammation, which is steatohepatitis. This next slide emphasizes the steatohepatitis. There's collections of neutrophils that are in the green circles, and this represents areas of inflammation in which the hepatocytes are actually dead and degenerating, and all you're left with is the neutrophil collections. The blue circles represent another thing that we see in both alcoholic and non-alcoholic fatty liver disease, although it's typically described with alcohol steatohepatitis, and that's Mallory-Denk bodies. What these are dense eosinophilic intracytoplasmic inclusions of material. You can actually stain them with ubiquitin, which is a kind of a protein mop-up type pathway. But anyway, these are the histological things that you see that are described as Mallory-Denk bodies. Another early change that you can see is hepatocellular swelling or ballooning. And this is where the cells are larger than normal hepatocytes, and the cytoplasm has this feathery, granular type appearance. Notice that these are not forming vacuoles like in microvesicular steatosis, which is something that it might be confused with. I put this slide in so you can compare ballooning on the left with normal hepatocytes on the right, and the arrows across the diameter of the cell, you can see that the arrow on the left with the ballooned cell is larger than the normal hepatocyte on the right. And so one of the key features, and I think it's hard to appreciate sometimes in these slides unless you go back and forth between normal and abnormal, is just the relative size of cells. So both of these are at the same magnification, so you can compare the size of the cells. Also note that in ballooning, the cytoplasm is much less dense. It has a watery, granular, or sometimes described as feathery appearance. The last consideration is steatofibrosis. At this magnification, you can appreciate, again, steatosis and inflammation, so we have steatohepatitis, but also in the middle of the image you get the impression that there's too much pink material and there's a vague nodular architecture to the underlying liver, which suggests fibrosis. At this higher image in the next slide, you can see in the middle a cell with Mallory-Denk bodies. There's some inflammatory cells in the lobule here, but the other thing is that it looks like there's pink material in and between the cells, and I drew some lines to try to highlight that. This it gives what was described in the notes for the study guide as a chicken fence wire type of fibrosis. So that's actually better highlighted on trichrome stain. So this is early, though prominent, alcohol-associated steatofibrosis. This is a trichrome stain which highlights the collagen deposition, which is typical of fatty liver diseases, and this is called a chicken wire fence fibrosis. It's difficult to see on the routine H&E slides from stain from the previous slides because these perisinusoidal fibers are so thin and delicate that it's easy to underestimate the degree of fibrosis. Finally, with progression of steatofibrosis, the trichrome stain shows linking of central veins to portal areas, forming nodules. Eventually, the steatofibrosis leads to hepatocyte atrophy and the collapse of such scars, and these areas where there's degeneration further compresses these regions. Eventually, these fibrous webs condense into compact fibrous septae, and with continued alcohol use or continued metabolic syndrome, whatever the cause of fatty liver disease is, the steatofibrosis continues to subdivide regenerative nodules, and this leads to the classic micronodular or Laennec cirrhosis of late to end-stage chronic alcohol liver disease or a non-alcoholic fatty liver disease. And so that ends this presentation. I hope it was useful in going over just by images some of the concepts that were outlined in the study guide notes. So on that note, I'll say cheers. Ta-ta.